Today, we have a great opportunity to learn a great experience from Josie Geller, but to reflect also about the health system for eating disorder, because we want to understand how we can maintain one of the pillars of the value to build this welfare state, the appropriateness that with equity is the fundamental basis of our Occidental societies, in a period when we have a great depth inside the public services, the cut of professionals, many other problematic coming back from syndemic. And so listening to what Josie Geller can offer to us, it's very important to rebuild a good approach to the best way to treat people affected by eating disorder. Josie Geller is a very friendship woman, that she's an associate professor of psychiatry in the Department of Psychiatry at the University of British Columbia, and director of the research at the Provincial Adult Tertiary Specialized Eating Disorder Program at St. Paul Hospital. The primary focus of her clinical research is patient-centered, surely, because we have to personalize all the time our care in collaborative care that promote client autonomy to improve, empower our clients, to improve well-being and to reach the best outcomes. And so the treatment have to be appropriate, to be effective. She's interested in client readiness and motivation, therapeutic alliance, and self-compassion, while Josie's work has focused primarily on the assessment and treatment of individuals with eating disorder, her clinical and research interests have been applied to other populations, including HIV, substance use disorder, and obesity. She is widely published as an internationally renowned speaker, and she's a great friend. And now she presents us a talk about right treatment, right patient, right time, and so the quality of care. Please, Josie.
Thank you so much, Umberto, and it is my pleasure to be presenting to this group. We were just saying at the beginning, I only wish that we could all be in a room together. I always find it wonderful to be able to have the live contact, but I'm so grateful that we have opportunities to share so globally this way, in part due to the pandemic and us now having such good technology for these webinars. So yes, I was hoping to tell you about a model of allocating treatment that we developed here in British Columbia, Canada, where I live. And I will be curious to know whether there are applications and whether this model feels appropriate and would be useful in other parts of the world. So the title of my talk is Right Treatment, Right Patient, Right Time, Maximizing Healthcare Resources for Best Outcomes in Eating Disorders Treatment. And I would just like to acknowledge with gratitude that where I work is situated on the traditional, ancestral, and unceded homelands of the Coast Salish peoples, including the territories of the Musqueam, Squamish, and Tsleil-Waututh nations. So what I would like to do in this talk today are three main objectives. I'd like to just start out by providing some clinical presentations. And these are just 4 examples of clinical cases that I thought would be helpful for us to get our wheels turning about thinking what would be the best type of treatment or care to offer these different individuals. And they will serve as examples at the end of my talk after I present our model. And I'd like to spend just a little bit of time speaking about some of our research on readiness, just a tiny amount, to provide some context for the model that we developed. And as Umberto was saying, this is an area of great interest for us and has been the topic of much of our research over the past 25 years or so. And then the last part of the talk will focus on presenting you the model that we came up with, which has a tool in it called the Short Treatment Allocation Tool for Eating Disorders, or you can summarize that with the acronym STATED, which we use to assign optimal level of care. And before I go any further, Umberto, am I speaking at a rate that you think is appropriate? I was warned not to go too fast. I just wanted to check in to make sure this is okay. It's okay. Okay. So let's start with some clinical presentations. The first person is a young man, and he reports dizziness and episodes of fainting and refusing to eat. His mother says that he went on a crash diet that spiraled out of control. So he's very ill, and he's been fainting, and he's lost a lot of weight. His mother is quite concerned. So I'd like you to just think about this case, because he will come back to us later. Someone who seems to be in an acute level of distress. What the young man is saying is, I don't need treatment. I don't know if any patients in different parts of the world ever say these kinds of things or have this kind of presentation, but we certainly have some of these individuals in Canada. The next person I'd like you to think about is a university student. She is reporting high levels of body dissatisfaction, as well as extreme dietary restriction and episodes of binging and laxative use. She is, however, able to go to school. She's just saying that she's very unhappy with the way that she looks. And she says, when asked whether she would like some help, don't ask me to change. So just to kind of illustrate that, here also is somebody who has some readiness issues. But in her case, she's not as critically ill as the first client. She's somebody who's able to function, is just saying that treatment is not something that she's interested in at this time. The next patient, this is somebody who had bulimia nervosa, who participated in evidence-based treatment. She did a course of cognitive behavior therapy, but each time that she began, she dropped out, or on one occasion, she completed the treatment and relapsed. So she never had a positive outcome from these treatments. Currently, she's actually very ill. She's unable to work due to the severity of her illness. And she says that she's not interested in recovery-focused treatment at this time. So she's saying no, and of concern, her illness severity is quite high. She's not acute, she's not dizzy and fainting like the first client, but she's nevertheless very sick. Oh, and sorry, what she says is, you can see here, been there, done that. I've been in CBT, I've done the kind of evidence-based treatment, and that's not something that I want to go back to at this time. Okay, the last patient is somebody who had a very severe case of anorexia nervosa. She actually also did an evidence-based treatment. She did a course of DBT. She was fully recovered for several months, but now, unfortunately, she returns and she's looking emaciated and depressed. So she's somebody who had a good outcome, who responded well to treatment, but has now relapsed. And when we ask her where she's at, she says, I'm back where I started. She's disheartened by where she's at. So I know when we have these kinds of presentations, if we were all in a room together, I would take a few minutes for us to think about, what are some of the reactions that we have. We often feel frustrated or disappointed, or sometimes, sad, sometimes fearful for our patients. These are presentations that are, some of them are not straightforward. And we're all left with the question of, what do we do? What is the best form of treatment? How can we best help these individuals? And that's what I'd like to touch upon in this talk. How can we organize our thinking to work out what is the best type of treatment to offer? Here in Canada, we have, and I'm sure it's true in many parts of the world, we have different levels of treatment, some that are less intensive and some that are more intensive, some that are provided in the outpatient community and some that take place in hospitals or in residential treatment homes. And up until fairly recently, let's say 10 years ago, we didn't have clear models for how to decide who should be going to the more intensive forms of treatment, who should be receiving the less intensive, and what should be the focus and content of the treatments that we assign to them. And so that was why I was commissioned to develop some guidelines to help us with that. And I'll get there in a minute. But before I do, I want to give you some of the background on some of the research that led to the model that we developed. And the key feature that we focused on in this model and that I was hoping to illustrate with these cases is the level of readiness for change that each of these patients had. We wanted to make sure, given the data that I'm about to present to you, that whatever recommendations we made were responsive to patient readiness. We have learned through years of research here that when we have mismatches or when we put somebody into a treatment that is not matched to their readiness, that our outcomes are sometimes disappointing and not as strong as when we make a good match. And I'll tell you a bit more about that with our research. So what did we learn? Many, many years ago, back in 1999, actually 2000, we developed something called the Readiness and Motivation Interview. And this really changed our thinking and our way of working here in British Columbia because of the valuable information it provided about our patients' responsiveness to treatment. The Readiness Motivation Interview is basically a conversation that we had with our patients where we, at the end of the interview, will have scores on stage of change and internality for each of the domains of an eating disorder. So dietary restriction, binge eating, compensation, and cognitive affective components of the eating disorder. And specifically, for each of these different symptom domains, we would have a score for the extent to which they are in pre-contemplation or not wanting change, the extent to which they're thinking about change, wanting treatment, but not necessarily at the point of taking action, and people who are actively working on change. We also have, as I mentioned earlier, an internality rating, which is the extent to which, if they are making changes, they would describe themselves as making those changes for themselves versus for somebody else. And this had some relevance with our follow-up data. What was key about the RMI, the Readiness Motivation Interview, was the stance that the interviewer uses. We have decided in my treatment center, and I think across the province, that in much of the work that we do, it does matter what we say, but it matters equally the way that we say it or the spirit of the interaction. And the way that we did these interviews with the RMI is the interviewer started out by saying, we have worked out that most people who come here for an assessment have mixed feelings about making changes, or that it's very common for them to have mixed feelings. And we've learned that it's unhelpful to push people to make changes until they've actually decided for themselves that that's something that they wish to do. And so the purpose of this interview is for the two of us to come up with the best understanding of where you're at right now with regard to what's going on with your eating, so that we can make the best possible recommendations for you that are suited to where you're at. And we also say, we want you to feel free to be honest in this interview. And so we say, at the time that we were doing the interview, we want you to know that what we talk about here is confidential, that we're not going to tell your parents or other people in your life. This is really for us to get the best possible understanding of where you're at. And also that me as an interviewer, I have no judgments or opinions about what's the right or wrong thing for you to do. I really feel that I can be of greatest use to you by the two of us having the best possible understanding of where you're at in terms of your readiness. So basically, the interviewer shows curiosity, tries not to make any assumptions, shows interest, is empathic. We acknowledge the universality of ambivalence and encourage exploration of mixed feelings. The interviewers were trained to do that. So using this interviewer, what did we find? Well, we were quite surprised, especially 20 years ago, where we offered in our treatment program good evidence-based, what I would describe as action-oriented treatment. What we found is that actually the large majority of our patients, 75%, their dominant stage score was pre-contemplation. 17% contemplation and only 8% action. And this helped us to understand why at that time we had such a large dropout rate. In fact, it was 42% of patients who were referred to our residential treatment were not completing treatment at that time. And this is, we understood to be that we were offering treatment that was well suited to the 25% of individuals who were in contemplation or action. So this gave us a clue that we were mismatching the nature of our treatment, and it led to some changes. I'm going to show you a little bit more of our research that solidified these changes that we made. Up until then, we were never able to predict which individuals dropped out, which individuals benefited the most from our treatment. And we've always been very fortunate to have a continuous quality improvement research program where everybody who comes to our program receives a baseline assessment, a post-treatment assessment, and a follow-up assessment. And we knew that some people had very good outcomes and also that some people did not complete treatment. We were not able to predict using symptom severity, duration of illness, comorbidities, all of the things that we included in our package until we started to assess readiness using the RMI. And when we used the RMI, we were very surprised to find that RMI scores predicted who enrolled in intensive treatment and who didn't, of those who were offered, of those who came into intensive treatment, who completed treatment and who dropped out. When we assessed their symptoms post-treatment, we could see how much they benefited from treatment. Baseline readiness scores predicted how much their behaviors changed, how much improvement we had in dietary restriction, binge eating, those kinds of things. And most amazing to me, when we assessed them at follow-up 6 months after they graduated from treatment, their baseline readiness and motivation scores predicted who maintained the changes and who dropped out from treatment. And this had such a profound effect on us as clinicians in the program, in understanding that we could really determine which individuals were benefiting from our treatment, that we made some significant changes. And we moved from having one main treatment that we offered to everyone, a one-size-fits-all treatment, you might say, to instead having a menu of options that was tailored to readiness. And in the course of doing this, we also developed treatments that was specifically focused at enhancing readiness so that we could ensure that patients who were referred into our treatment programs that required a certain level of readiness, that they would only come in when they were in a place that they were most likely to benefit. And we also changed the dynamics of it, whereas it used to be us sort of pushing our patients into those treatment programs. We had preparatory treatments that provided them with exercises and opportunities to understand their eating disorder, opportunities to understand what recovery might look like. And the dynamic changed that rather than us be pushing them in, they would have to say, please, I would like to come into this treatment, and basically be the ones initiating coming into treatment. So it didn't feel like they were being forced to do something that they didn't want. It was instead them making an informed decision that this is something that they want, that they ask us for. And when we made this change, our dropout rate almost immediately was reduced from 42% to 20%, and it's gone down even further now to about 13%. So we have very high completion rates and the outcomes of completers were always very strong, but now we have a higher proportion of those who come into our treatment who complete. These findings were replicated in adolescents. So we came up with a readiness motivation interview for adolescents. And since then, we have actually turned this interview into a questionnaire. It's called the Readiness Motivation Questionnaire. And it assesses readiness in the same way, but it's kind of like the equivalent of the EDE and the EDEQ. In fact, we use the EDE symptom domains as springboard for the readiness questions. And the EDEQ has also been validated both in adults and in adolescents. We were not the only ones who learned this about our patients, that the important role of readiness. Tracy Wade and her student did a meta-analysis back in 2016, and they did an overview of a large number of studies that were looking at predictors of outcome. And it wasn't only in our program that greater motivation to recovery was found to be the most consistent baseline predictor of outcome across studies in different populations and different parts of the world. And the same thing with dropout was predicted by lower baseline motivation to recover. So using this information about readiness and motivation, which is relatively recent, that we've only have, the meta-analysis came out less than 10 years ago. We wanted to know in British Columbia, how can we ensure that we assign patients the right treatment for the right patient at the right time? And so the last part of my talk, I would like to tell you about the model that we came up with and how those patients that I described at the beginning optimally fit into this model. So back, I guess this was in around 2013, the Ministry of Health here in British Columbia commissioned me to create clinical practice guidelines for the purposes of advising treatment across the province of British Columbia in care for people who have eating disorders. So those guidelines were published in 2013. It was a really wonderful process. I was given the opportunity to have a consult group here in British Columbia with all different disciplines and individuals from all different parts of the province. And I also had an international group of experts that advised me from other countries in the world, both pediatric and adult, who were giving me some help and critiques throughout the creation of these guidelines. So we were very lucky to have a collaborative process in which they came together. We also had a patient and family advisory committee here in British Columbia that was comprised of individuals with lived experience who had been through treatment in our programs, as well as their family members who gave us critiques and their input at each stage of this guideline creation process. The most important part of the guidelines, they are not new anymore. They came out in 2013. And so some of the details part will need to be updated with new research that came in. But the most fundamental model that we came up with, the guidelines, has not changed. In fact, it's only become stronger since we first developed it. And it's what I'd like to tell you about, because I think it offers a very nice heuristic for utilizing patient information in deciding what is the best level of care. And it's called the Short Treatment Allocation Tool for Eating Disorders. As I said earlier, we just call it the STATED. And it is empirically based. It's based on the evidence. And I think the strength of the STATED is that in determining what is the home, what is the optimal treatment for an individual, we have 3 dimensions that we assess. And unlike some other guidelines that I've seen, where sometimes some assumptions are made about how, for instance, medical stability and engagement may go together. For instance, in the old APA guidelines, there was an assumption that people who were more medically acute necessarily had low readiness, and people who were less acute necessarily had high readiness. In the STATED, individuals are allowed to co-occur. They could have, we know, for instance, that some people who are not medically acute also have very low readiness. And similarly, some people who are quite ill who have high readiness. So the stated allows a full range of presentations of eating disorder patients, and I'll explain to you how this works. So the medical stability dimension, as you would expect, simply assesses a patient's immediate medical risk as unstable or stable. And this is to ensure that medical issues are prioritized. We want to know at the outset that nobody's going to die, that we're going to ensure that anyone who is in an acute state receives a hospital admission, and that their safety is maximized. So that one's a fairly easy one. Life interference refers to the level of disruption in a patient's life, and this could be high or low. So this is things like, are they able to go to school? Can they keep a job? How is their quality of life given their eating disorder? And the importance of life interference is to ensure that we provide the more intensive resources for the patients that most require them. So individuals with higher life interference and more symptom severity who are unable to work or manage, that they would receive more intensive treatment than those who would be able to receive treatment while they're still functioning and perhaps going to school or having other things of meaning in their life. And then the final dimension, and this is the one that's more unique from the stated, is engagement and readiness. This one is to ensure that we match treatment to patients' wishes and needs. And it's a little bit different for individuals of low versus high symptom severity. So let's start with people who are whose life is not that disrupted from the eating disorder, whose symptom severity is lower. If they have lower symptom severity and they have a high level of readiness, then those would be the perfect candidates for our evidence-based treatments, cognitive behavior therapy, family-based therapy, DBT. We would see them as being perfectly poised to benefit from those treatments. On the other hand, individuals who are low symptom severity and who have lower levels of readiness, we would see them benefiting from outpatient treatment, but where the focus is more on engagement. So we might provide education, we might do motivational enhancement therapy, we might examine what are the barriers to engaging in action-oriented treatment for them, to try and get them to a point that they would benefit from outpatient recovery-focused treatment. And the purpose is to maximize their autonomy, to decrease dependency, dropout, and relapse. Always the case with readiness. On the other hand, for patients who have high symptom severity, who are quite ill, we would also assess readiness. With higher levels of readiness, we would see those as individuals who would benefit from intensive treatment. So this would be what we would describe as our more intensive treatment environments, such as a residential treatment program or day therapy, where we might have a lot of resources, maybe a multidisciplinary team, a nice framework and container of support where individuals can have support around mealtime and around not using behaviors post meals, lots of encouragement for weight restoration and so on. So those who are ready and who are wanting to perhaps gain weight if necessary or interrupt their symptoms, they would be seen as good candidates for intensive treatment. And then the last category, I think this is the one that's received more attention more recently, are people who are quite sick. They aren't necessarily requiring a hospital admission immediately, but who are saying very clearly that they are not interested in recovery-focused treatment. This is where we would recommend outpatient with inpatient support in an engagement focus on harm reduction, quality of life model. And this is where we would be working with them on goals that are meaningful to them, but that are not necessarily full recovery. And we have found that very often, particularly for individuals who have many times not benefited from more action-oriented intensive treatment, that this way of working with them is a way of not alienating them. Very often when we don't focus on full recovery and focus on things that are meaningful to them, once they start to develop things in their life on a goal, for instance, that might be to decrease social isolation, or to be able to take a course at school, or to do something that they're currently unable to do, that through this backdoor approach, they often now see the eating disorder as getting in the way of something that is coming into their life that is meaningful, and very often move over to be involved in action-oriented intensive treatment. And we find that it just takes away the battles. And when they do end up coming into hospital, rather than it be in a crisis, unplanned admission, it will come in the context of a planned admission where there is an entire team that has created a framework of safety that the individual has agreed on. And so the admissions are not focusing in that they're not urgent. Instead, they are planned and very often as brief as possible to stabilize the individual and get them back into the community. I'm happy to talk more about this model if people are interested or have any questions. So coming back to this issue of right treatment, right patient, right time. This is our objective. Well, I thought it might be interesting to just take you through what would the patient's journey look like if we're using this stated model. So in the stated, the first thing that we would do always is we don't want anyone to be so ill that, that they're at risk of dying or any medical repercussions. So the first thing we would always ask is about their medical stability. If they are in an acute state, then we actually don't need to know any other information. We don't need to know about their readiness or their symptom severity. If they are in an acute condition, then they require a hospital admission. They would go straight to hospital where the focus would be medical stabilization. And we have learned, and the data also support this, that we want to have these admissions as brief as possible. I know there was a time that people were coming into hospital for, very lengthy admission times, several months, even up to a year. We have not, and I know others have shown, not seen this to be beneficial for patients, and that they do much better when we keep the admission as short as possible, and also have them leave feeling like it was a successful admission where the purpose of the admission was stabilization and not trying to focus on full recovery in hospital. We would see that as something that would optimally take place outside of hospital. So we assess medical stability. If they are unstable, we would have a brief hospital admission. If they're stable, then we would not need for them to go to hospital. And that takes us to the next dimension of the stated, which is to assess their symptom severity. So now we're looking at how much is their life being interfered by the eating disorder? Is it to a large extent, or are they still able to function? And let's review each of these options. Let's say their symptom severity is very high. At that point, we would then assess the question of their level of readiness. And you don't need to do a full readiness motivation interview in order to do this. We have found that by having the stance that I described, that open, no assumptions being made, showing curiosity and interest in the individual, letting them know that there will be no negative consequences for them to describe themselves as not being ready, letting them know that it is our purpose in life to ensure that we offer care that is most closely matched to where they're at. Then very often they will tell us exactly where they're at with regard to their engagement and readiness. And for those individuals who are saying, yes, I feel like my life would be better without my eating disorder, and I'm motivated to, roll up my sleeves and do some work, and that might mean, gaining some weight or making changes to my behaviors. Then for individuals who are very ill and unable to function, and probably who haven't benefited from less intensive outpatient resources, we would see that as the perfect candidate for a high intensity day residential or inpatient treatment with a focus on recovery. And in our tertiary care program, this is where people who have the most severe eating disorders in the province, this is where they would receive treatment. And we have an excellent, it's a 12-week program. They come in and there is a very clear frame where they are expected to eat a certain amount and gain a certain amount of weight if they're underweight. and they receive many tools and skills and opportunities to understand the function that their eating disorder had and have alternate ways to have the highest quality of life. Units focusing on self-compassion, all of the components of a full recovery. That would be the treatment that we would wish for them. Instead, the individuals who have high symptom severity and who instead say that their level of readiness is lower, that would be the harm reduction quality of life model I was telling you about earlier. This is a treatment that we founded about 20 years ago, and it turned out to be incredibly successful with individuals who previously were what we would call revolving door hospital admissions. I don't know if you have any of them in Italy, but we had some patients who would come to treatment. They would receive enough care to no longer be in medical crisis. They would be discharged, and within a month or two, they would be extremely ill again, and very often coming back into treatment. We found that when we started to work with these individuals using this harm reduction focus on quality of life, that in some cases, it moved to having planned admissions that were further apart, that were very brief, and that were in the context of goals that were meaningful to them in the community. And in some cases, it literally stopped their need for hospital admissions. We were able to keep them stable and happy outside in the community. And as I say, in some cases, even getting to a point that now that they had a higher quality of life, they were wanting more action-oriented treatment and coming into our intensive residential treatment. Okay, what about for individuals whose symptom severity is low? Well, these are the individuals who we would be assigning to outpatient treatment options. And here, these are fairly straightforward. Those who have a higher level of readiness would be the ones who would be receiving our evidence-based treatments that we have out there, whether it's CBT or FBT or DBT, that focuses on recovery. And that's very often the perfect fit and those who benefit the most from these treatments. And in contrast, those who are not as ill and whose level of engagement and readiness is low, those individuals we would put into some kind of engagement type of intervention. It might be a psychoeducation group or a motivational enhancement group where they get to understand the factors that contribute to their eating disorder and help them work through what would be the barriers to engaging in action-oriented treatment. And sometimes this is a very brief time before they would move over to the other arm. So just to wrap up, let's go back to those 4 cases that we started with and see how they would get classified or what treatment they would be assigned using the stated instrument. So the first individual who said, I don't need treatment, but who was extremely ill, who was dizzy and fainting, and it looked like there were some real medical acuity issues. I'll give you a second to guess where you think that individual should go, and then I'll show you on the stated diagram that individual would fit here. It doesn't actually matter what their readiness is or their symptom severity. If they are experiencing acute symptoms that could put their life at risk, we would want them to go straight to a hospital admission, and we don't need to have any further information. So that one's kind of an easy one. Well, what about the individual who's not that sick, going to school, but who is clearly saying, don't ask me to change. They're saying that they're not interested in working on recovery at this time. Where would that person belong in our stated model? Because I described them as somebody who is functioning and able to go to school, we wouldn't see them as having a high symptom severity necessarily, although it would be important to assess for this. Let's just pretend that we did assess them and that they didn't have any medical conditions that needed to be attended to. This would be somebody who we would want to work with in an outpatient capacity and be focusing on education and understanding what their life is like, what would be barriers to them considering more intensive treatment, and just working with them in that capacity. And as I say, for many of these individuals, they wouldn't necessarily spend a lot of time here. We would just make sure that we did this before moving into a recovery-focused arm. Okay, what about the individual who was very sick and who has been through treatment and has never benefited, either not benefited didn't even stay in treatment, or when they did stay in treatment, they relapsed immediately and are now saying they're not interested in going back to recovery-focused treatments. So this is really exactly the patient I was just describing, who would fit into this arm of outpatient treatment with inpatient support as necessary. We wouldn't force them to do something that they've already done and that has not been successful for them. We would work with them on goals that are meaningful to them, and hopefully I address some of the barriers that they encountered when they made changes, while keeping them safe in an inpatient capacity, brief admissions if necessary. And then finally, the individual who had a very positive response to evidence-based treatment, but who comes back, who has relapsed and lost weight again, says, I'm back where I started. Where would this individual go? What I'm hoping that you're all saying is, well, we know that she has relapsed. It doesn't sound like she's medically acute at this stage, but we don't really know until we ask more questions. So we would need to know how much is her life being interfered to determine symptom severity. And then we would need to find out, is this person ready to have another trial of evidence-based treatment, or are they wanting to do, not that the other treatments aren't evidence-based, to do action-oriented treatment, or is this somebody who would benefit from an intervention that focuses on enhancing readiness and or quality of life? So this one, we clearly need to do some more assessing. Well, that's what I wanted to describe to you today. Some of the research that led to the development of the stated, and then some case illustrations that hopefully give you an example of how we're using the stated in British Columbia right now. So just to sum up, I hope that I've conveyed to you that readiness is a key predictor of outcome. And it's, I think, really important in working with individuals who have eating disorders to encourage open discussion, to not make any assumptions about where they're at. And we've learned that readiness is something that changes, and that it's important to continue to assess it throughout treatment. I'd also hoping that using readiness to determine optimal type of care is advantageous, and that the recommendation that we would have is to always offer a menu of treatment options. And if the stated is something that you think could be useful for your environment, it would be a tool that could be used to allocate the type of care, and also to ensure we use the stated sometimes to advocate to, for instance, the decision makers or the Ministry of Health, if any of those boxes are missing in your community, to advocate. The evidence suggests that we offer the best care to individuals with eating disorders if we have all of these different levels of care. It's not enough to just have an inpatient unit. It's not enough to just have residential care. We need to have a menu of options to meet the needs of optimally of all of our patients. And I know that this is not always easy when, Umberto and I were talking at the beginning that, we are so under-resourced to treat eating disorders in so many parts of the world. This would nevertheless be what I would wish for and what I would look to gradually build over time and advocate for. And that's all I have to say today. So I would like to thank you for your attention, and I'll just leave some space now if anyone would like to ask any questions. I don't know if it makes sense. Should I take us off screen share? And Umberto, if you're speaking, you're on mute right now. I still don't hear you. Still don't hear you.
Yeah. Okay, now perhaps I can speak now.
Yes, I can hear you now.
First of all, I want to be really appreciate your speak because it's fantastic. It opens the mind. For me, it's an ancient point of view because when we try to offer the quality care, we say right patient, right care, right time, right place, right place. And so it's absolutely fantastic. But I want to ask to you some questions. For example, first is, what about the caregiver approach inside this journey? And what the role of the loved one when you have to improve motivation?
Yes, a fantastic question. And it's like you are a plant, Umberto. Like I asked you to ask that question because that is actually the topic of a research project we have going on right now. We feel that the role of the loved ones has been neglected, particularly in the care of adults with eating disorders. I think in the pediatric youth population, family-based therapy is so focusing on including adults. And we have learned that for adults, very often the parents have felt here in Canada anyhow, left out or not included, that very often it is their child that gets to decide how much they are involved in their treatment. And sometimes at the beginning anyhow, the children are not wishing for their parents to be involved. So we are doing a study right now where it's a follow-up to a study that we did with individuals who had recovered, so individuals with lived experience who had recovered. And we asked them, what did your family members or loved ones do that was most helpful to you in your recovery? So these are adults who are not looking for their parents to encourage them to eat a meal or to police what they're doing as far as their behaviors are going, but who very much want a good relationship, a loving relationship, and supportive with their loved ones. And what the individuals with lived experiences told us that they most wanted from their loved ones was, I could summarize it really in one word, which is validation.
You can use more because it's so fantastic, your expression. You can use more.
What they told us was they wanted their loved ones to provide space and listening, to be curious and interested in their process, to offer a compassionate perspective for what they were going through, to not push them too much and not be unaware of their struggles, but to be matching what they are suggesting to what their loved ones are saying they need, to really recognize and celebrate when they see how hard their loved ones are working. They said it's very common that when they are, rolling up their sleeves and eating more, gaining weight, or not using their behaviors, that very often loved ones, particularly of adults, go, phew, we don't need to worry about them. We don't need to talk about that anymore. We don't have to give them so much attention. But they were saying from their perspective, that's often when they need the support even more, because now they don't have their coping strategy of their eating disorder, and they're often finding it very challenging and difficult. They find it very helpful for their loved ones to recognize how hard they're working, to show that they see this, and also to remind them of other difficulties that they've overcome in the past, that to show them of their strengths, which made them feel empowered. And lastly, they really appreciated when their loved ones didn't make it seem like, they're up here and their loved one with an eating disorder is here, a way of showing that we all have difficulties, we all have struggles, and we all benefit from compassion and support, and from being kind to ourselves in times of difficulty. And when loved ones modeled this sort of way of relating to themselves in times of difficulty, that actually made their loved ones feel inspired to also be kind to themselves in their own recovery journey. So we're currently doing a project focusing on how to enhance the role of loved ones, how to provide support to them, whether or not their loved one is wishing them to be involved in their treatment per se, but helping the loved ones first themselves to have validation for how hard it is to be the loved one of someone going through an eating disorder, and in turn have enough support themselves that they can also offer this validation to their loved one. And this seems to be what our patients are most asking for right now.
Katharina, did you have a question?
No, I did not have a question. I found this very, very interesting. And it will make me revalidate a lot of things, because like when I see somebody with a very low BMI and we try to make them go through it, it might also even be through a court order. And I found it really interesting to see that a day hospital might actually be the better thing than.
Yes, and depending on their level of readiness, we may actually even work with them in an outpatient capacity until they are showing
yes,
it's something that they're really wishing to work on. Yes, yes, we've really moved to
so
admission.
I found this you're recording this, so are you emailing these things again so I can look at it tomorrow again, or over the weekend? Yeah, I see your recording.
This will be up on the European chapter of AED's website in about 24 hours or sooner.
Okay, so but since I already registered anyway, so you will probably email me the link or something.
I can email you the link, Katharina, when it's up. Yes, ma'am.
Yeah, that would be really, really great, because this was very, very interesting.
Absolutely, absolutely. Other questions? Can I summarize, Josie? Can I summarize in this way? You don't prescribe care. You have to adapt all the times with the level of the sufferance and the compliance by the patient, client, and also his family. Is it correct? This is summarized?
Yes, that, well, we want to be responsive to their level of readiness, and we develop our intensive treatment resources to provide a frame that will offer all the support for full recovery for individuals who are saying that is what they wish for. And what we found is that those are the individuals who complete treatment, who receive the most benefit, and who are least likely to relapse. And so now we do everything that we can with preparatory interventions beforehand, so that when they come into this treatment, they don't feel so overwhelmed by all the changes that they're being asked to do, and instead are hitting the ground running and are receptive to the care. So they're happier and we're happier, and it really doesn't require so much work to do these preparatory programs. For instance, our residential treatment right now, they cannot come into the residential treatment unless they have participated even briefly in what we call our readiness program. And this is an outpatient group, so it would be in the stated at the less intensive treatments, that just provides them with opportunities to experiment with eating in a group, with opportunities to know what are all the components of the intensive treatment program, and opportunities to learn some skills and learn, wow, if I had these skills, I wouldn't need my eating disorder so much. So now I really want to learn more of these skills so that I don't need this eating disorder at all. And then they're saying, okay, sign me up. I want to go there. Instead of them coming into a treatment, suddenly being asked to do all these things that are so scary for them, being overwhelmed and not being able to complete the treatment.
I actually, can you hear me?
Yes.
Yes.
Okay, sorry. What is the BMI that you would have for an eating disorder treatment instead of saying this is so dangerous, it has to be a medical treatment?
Yes.
What's the score of that? Because I think we have 11 here.
Yes. Katharina, I know that over time, we have put a little bit less emphasis on the BMI, and they've looked, I know that our medical team and dietitians will look at a combination of factors.
Yeah, but would you take somebody with 9?
No,
no,
not in the residential treatment. In fact, that's one of the ways in which we use our inpatient unit is for people who are underweight and who are probably cognitively not in a place that they would be able to make use of all of the skills and intensive underlying issue work that occurs in residential treatment. They might choose to come in instead, perhaps even for a series of inpatient admissions, where each time they come in, they have a goal to gain a little bit more weight so that they...
Yes, but then, sorry to interrupt you, but then that is really almost a like medical emergency when they are BMI 9 or under 11.
So that's an excellent question, because we also distinguish between a medical urgency admission and a symptom interruption preparation for future treatment admission. And these are actually usually taking place in 2 different parts of the hospital, where the medical stabilization admission would not happen on our intensive treatment unit. It would happen on the medical unit, whereas the symptom interruption preparation for future eating disorders treatment would take place in the specialized care area, where they would have more of the multidisciplinary team. There would be a framework and more support around eating and building skills. So we actually have 2 different types of inpatient admissions, and it's quite important, we find, to keep them separate, because people who are coming in to gain weight in order to ultimately get into the residential care are sometimes triggered by people who are so sick that, you know, they're going to die unless, you know, and very often who might need to have a nasogastric tube feeding or that kind of thing. So we have 2 separate programs within our inpatient care.
Okay. Thanks a lot, Josie. It was wonderful to listen this kind of lesson, because it's crucial about the evidence. This is a fundamental aspects that you can't offer strictly model of care, where you have to choose the model correct with the right client. This is the best level of care, not the good model in se. Thanks, Josie. That is really important for everybody of us. Thanks.
Thank you so much for having me.
No, we are happy. We are happy to listen from your experience, because Canada, I said before, Canada for me, from Italy, it was the master of the quality of care. And so all the time that I listen something that arrives at the high level of Canada, I stay really attentive, because I learn much than from the other, my experience, for example, is more lesser than yours. Thanks to everybody. You can this is recorded, and so you can reach it inside the web of the European chapter. And so you can put www.european-chapter.ad, and so you can find it, the registration. And remember, next webinar,
or you will just email it to me, what you said before.
Okay. You put inside Google, you can put European chapter AED, and it's ranked on the first. Okay? Thanks to everybody. Thanks, Josie, again. Thanks, Elisa, as always, because with Elisa and with Dawn, we form a very strong team. Thanks to everybody. Ciao.
Bye, ciao.
See you on September, 14 September, next webinar.
Thank you, everybody. Thank you, Umberto.
Thank you, Umberto. Thank you, Lisa.